Thanks very much for having me back again. It's a pleasure to be here, and thanks to everyone for tuning in. So I'd like to talk about a topic that's sort of one of my favorite aspects of GU pathology, and that's emerging entities in renal tumor pathology. Let me see. Advance here. I have no disclosures relevant to this presentation. And so if you look at the ISUP molecular consensus papers that were recently published, I had the opportunity of being the first author of the kidney cancer section. And if you look at that paper, we commented on a few entities that we thought were recognizable as new emerging entities that would be well suited to be considered distinct entities in future classification schemes. And I'll kind of highlight some of those. I think with everything that I'll talk about today, I'll try to emphasize whether my interpretation is that a particular entity is ready for diagnostic practice or not. So what's the significance of this topic? Some emerging entities have more favorable prognoses, and we'll talk about at least one or two of those here. Others are more aggressive and are relevant for prognostication and for patient care. And then still others are associated with inherited tumor syndromes that have, of course, implications for that patient and also their family members. So I'll try to highlight all of these aspects, especially the clinical relevance, as well as whether these entities, in my interpretation, are ready for patient care. So the prototype for this topic in my mind is the entity clear cell papillary renal cell carcinoma. Now, Dr. Clouston gave a lecture on renal tumor morphology and a few weeks ago. And so if you refer back to that, he already did cover clear cell papillary renal cell carcinoma. So I won't touch upon this too much today, but I wanted to at least mention it partly because of similarity to some of the other entities that we're going to talk about, and partly because it's kind of the prototype of kind of recognizing a new entity that I think does have clinical significance. And so if you scan that QR code that's located in the upper corner there, that will take you to a review article that I recently wrote on the topic of clear cell papillary tumors, which really covers basically everything that I know about that entity. But just for a super brief review of clear cell papillary renal cell carcinoma, it can look a lot like a clear cell renal cell carcinoma, as you can see in the upper left. But the key findings that would help you to recognize one of these include the branching glandular architecture, as you can see in the upper right, or papillary formations, as you can see in the lower left, or a nuclear alignment like sort of the piano key pattern, or resembling early secretory endometrium with the subnuclear vacuoles. Those can all be clues to recognizing this entity. And of course, as I think most of us know, it has a very reproducible immunohistochemical pattern with diffuse cytokeratin 7, minimal or negative CD10, and negative Amicar. And so that constellation of features contrasts to both clear cell and papillary subtypes of renal cell carcinoma. Interestingly, these tumors also label for high molecular weight cytokeratin and GATA3 frequently, which kind of suggests to me that this has more of a distal nephron phenotype, despite looking like a clear cell morphology, which we usually think of as being more of a proximal nephron phenotype. And so again, I won't get into this entity too much, but just the most important thing in my mind for this entity is that it has extremely favorable behavior. There's almost no convincing reports of aggressiveness or metastasis, except for perhaps one or two rare debatable cases. Although of note, it can be multifocal and or bilateral for as yet not incompletely understood reasons. So again, if you'd like to read more, you can scan that code. And I won't talk too much about clear cell papillary renal cell carcinoma today, but I will talk about some entities that have some overlap. One entity that I think has some overlap with clear cell papillary is so-called renal cell carcinoma with leiomyomatous or smooth muscle stroma. And in these tumors, you have abundant epithelium that's kind of dispersed in this sea of smooth muscle stroma. And I'll try to convince you today that I think this is unrelated to clear cell papillary renal cell carcinoma, but there is some overlap in the immunohistochemical phenotype. And so up until recently, there was some discussion as to whether they were potentially related. And in particular, they're both positive for CK7, negative for Amicar, and frequently positive for high molecular weight cytokeratin. So several names have been used for this entity. Very recently, a paper by the Genitourinary Pathology Society group published on emerging entities and proposed the name renal cell carcinoma with fibromyomatous stroma to kind of unify all of these existing names, and also putting that prefix fibro in there to convey that it's not always totally muscular. It also can be somewhat fibrous and muscular. But here on the slide are some of the other names that have been used for this entity over the years. This is an example of one of these that I encountered at gross examination, and even just seeing this grossly, I was highly suspicious that something special was going on here. This is a partial nephrectomy specimen, and although you do see this circumscribed mass here, it doesn't bulge from the cut surface of the specimen like a renal cell carcinoma normally would. It's very flush on the cut surface with these bands of fibrous tissue, which made me wonder if there was a mesenchymal element that was kind of binding everything together more than a usual renal cell carcinoma. Something that you can see microscopically with these tumors is that the smooth muscle entraps the epithelium, but it also can spread out into the perinephric fat. And in this case, you can see it kind of wraps around lobules of fat, which is an unusual finding that you can sometimes see with these tumors. When you look at the body of the tumor itself, you can see the smooth muscle and the epithelial elements that are kind of intermingled. As I mentioned earlier, these do have an unusual immunohistochemical phenotype that overlaps with clear cell papillary renal cell carcinoma with perhaps a couple of subtle differences. So they're positive for carbonic anhydrase 9, which is a marker of the hypoxia and VHL pathway, commonly positive also in clear cell and clear cell papillary tumors. They're frequently positive for cytokeratin 7, which resembles that of the clear cell papillary phenotype, as we talked about. They are frequently positive for high molecular weight cytokeratin, like clear cell papillary tumors. However, in contrast to clear cell papillary tumors, my experience with these is that they're frequently CD10 positive. So although there's that overlap in the immunohistochemical phenotype, the CD10 positivity, in my experience, is slightly different. So actually, two recent studies looked at renal cell carcinomas occurring in patients who had tuberous sclerosis. As we know, tuberous sclerosis patients develop angiomyolipomas of the kidney, but occasionally they also do develop renal cell carcinomas. And these two recent studies that are cited at the bottom, number 1 and 2, looked at the types of renal cell carcinomas that occurred in these patients. And both of them found that a subset of the renal cell carcinomas in tuberous sclerosis patients have this prominent fibromuscular stroma with kind of a papillary and clear cell morphology. You might wonder whether since patients with tuberous sclerosis develop angiomyolipomas, is this like a collision tumor of a renal cell carcinoma and an angiomyolipoma? But it seems that it likely is not, as the stroma appears to be negative for melanocytic markers and cathepsin K, contrasting to angiomyolipomas. So recently, Dr. Sean and colleagues published a nice series of these renal cell carcinomas with leiomyomatosis stroma and found that they frequently do have somatic mutations of tuberous sclerosis 1, tuberous sclerosis 2, and the mTOR genes. So the way that I am now thinking about this entity is that probably it has both inherited and sporadic forms. So much like clear cell renal cell carcinoma can occur in the setting of von Hippel-Lindau disease with germline mutation of the VHL gene, as well as sporadically in the absence of a germline mutation. These tumors probably occur both in the setting of tuberous sclerosis, where you already have a mutation of one of the TSC genes, and also sporadically, where you perhaps have 2 hits to the tuberous sclerosis and or mTOR genes that create one of these tumors. So just to compare, we talked a little bit about how clear cell papillary renal cell carcinoma and renal cell carcinoma with smooth muscle stroma are similar and different. And here on this slide, I've highlighted some of the slight differences. So CD10, as I mentioned, is positive in the renal cell carcinomas with the smooth muscle stroma and not so in clear cell papillary. You have, of course, the C of the smooth muscle stroma that the epithelium is kind of floating in, which is different in this entity. The smooth muscle extending away, sometimes entrapping other tissues, as I mentioned, is a slight difference. And then genetically, the recent study by Dr. Sean and colleagues showed that you have TSC1 and TSC2 alterations commonly in these tumors, whereas clear cell papillary renal cell carcinomas, a number of them have been sequenced in various studies and have not been found to have any recurring genetic mutations. So perhaps that's now the strongest piece of evidence that suggests that these are not related to clear cell papillary renal cell carcinoma, despite the overlap of the immunohistochemical profile. So as I mentioned briefly earlier, clear cell papillary renal cell carcinoma has excuse me, sorry, clear cell papillary renal cell carcinoma has very minimal, if any, malignant potential described. However, with the tumors with the smooth muscle stroma, a few cases with lymph node involvement, particularly in tuberous sclerosis patients, have been described. And so it seems that there is also a slight difference in behavior, whereas clear cell papillary almost never seems to behave in a malignant fashion. There's at least some lymph node involvement that's been described in these tumors with the smooth muscle stroma. So these renal cell carcinomas with smooth muscle stroma or fibromyomatous stroma, are they ready for routine practice? My opinion is that they are, at least in your reports. What I usually do is give this diagnosis and give an explanatory comment explaining what we know about them so far. So in my note, I usually say that they're different from clear cell renal cell carcinoma. And actually, I'll show on the next slide an example of a note that I use, and sometimes mentioning that a subset of these are associated with tuberous sclerosis. So here's an example of the note that I've been using. I modify this over time as we learn more about these tumors, but it basically highlights that this is a recently recognized tumor. It appears different from clear cell renal cell carcinoma. They frequently have mutations in the TSC-mTOR pathway, and including some patients who have tuberous sclerosis complex. And then I mentioned that the behavior appears mostly non-aggressive, although rare lymph node involvement has been described. Something that seems slightly related to this concept of renal cell carcinoma with leiomyomatous or fibromyomatous stroma is renal cell carcinoma with mutation of the TCEB1 gene or ELOC gene. And a few years ago, a group primarily from Memorial Sloan Kettering Cancer Center looked at the Cancer Genome Atlas and another large cohort of sequencing data from a Japanese group of clear cell renal cell carcinomas, and they found 11 tumors that looked like clear cell tumors, yet which had TCEB1 gene mutation instead of VHL gene mutation. And rather than having loss of chromosome 3 where the VHL gene is located, they had loss of heterozygosity for chromosome 8 where the TCEB1 gene is located. And so in this study, the tumors appeared to have prominent fibromuscular stroma. They were also cytokeratin 7 positive. And so that, again, raised the question of whether this mutation explains the renal cell carcinomas with the smooth muscle stroma that we just talked about. However, I'll try to show why I think this is not entirely the same as those with the TSC1 and TSC2 mutations that we just talked about. This tumor seems to lack the morphology of clear cell papillary renal cell carcinoma. In my experience, at least, it's less recognizable. The initial series published by Hakimi and colleagues in Modern Pathology suggested that the behavior of these was quite favorable. However, a later series published in European Urology Focus, reference number 4 there at the bottom, found TCEB1 or ELOC gene mutations in renal cell carcinomas with aggressive behavior, suggesting that they are not always indolent, but I think more data are needed on that. So at the bottom here, you can see it's debated whether this should be lumped in with those tumors containing smooth muscle stroma. My interpretation is no, although this is certainly an area that's debated among GU pathologists. Here's an example of one of these cases from the Cancer Genome Atlas database. You can see it looks very much like a clear cell renal tumor, and there's a bit of fibromuscular stroma on the left there. But to me, these are not entirely easy to differentiate from clear cell tumors at the present time. And so I think this is a challenging diagnosis at present. I realize that this slide is busy, and I don't mean for you to study it in detail, but if you're not a super kidney tumor enthusiast like me, feel free to take a quick nap. If you are one of the 5 or 10 people in the world who's really super excited about this like I am, you could look at this table in a little bit more detail. But I tried to highlight what to me are some of the subtle differences between those with the smooth muscle stroma and those with the TCEB1 or ELOC gene mutations are. So TCEB1 is the former name for this gene, and ELOC is the newer name for this gene. So it highlighted in yellow are some of the differences. Cytokeratin 7, although it's frequently positive in those with the smooth muscle stroma, those with the ELOC mutations, and also clear cell papillary renal cell carcinoma, it's less consistent in those with the ELOC gene mutations. In the study by Hakimi and colleagues, some had as low as 10 to 15% of the tumor being positive, which to me would be rare in clear cell papillary or those with the smooth muscle stroma. Carbonic anhydrase 9 is positive in all 3 of these entities, but it lacks the cup-shaped pattern that's been described in the clear cell papillary tumors, the cup-shaped pattern is lacking in those with the ELOC gene mutations. High molecular weight cytokeratin, whereas it's often positive in clear cell papillary, and those with the smooth muscle stroma, it's typically negative in the ELOC mutated tumors. Amicar, we don't have much data published as yet, but anecdotally from some folks that I've talked to regarding these ELOC mutated tumors, some positivity has been encountered in the ELOC mutated tumors. So that could be a difference once we see some more data. Interestingly, Satish Tiku and his group from Memorial Sloan Kettering Cancer Center did some work a few years ago, presented as an USCAP abstract on the mitochondrial density in some of these tumors. And to me, it appears that the mitochondrial density seems to be very low in clear cell papillary renal cell carcinoma based on his abstract. And also some electron microscopy that we've done on these tumors. The same is likely true of those with the fibromuscular stroma. However, in the abstract from their group that was presented at USCAP a few years ago, they found that mitochondrial density was not depleted in the ELOC mutated tumors. So again, that's a very subtle, small difference between these tumors. Michelle Hirsch has some preliminary data that had been presented as an abstract at the USCAP meeting a few years ago, showing that these tumors with the ELOC gene mutations frequently have monosomy for chromosome 8. And likewise, some data from an abstract that we presented suggests that those with the smooth muscle stroma do not have monosomy 8, nor does clear cell papillary renal cell carcinoma. And then, of course, the mutations appear to be different across these three tumors with TSC1, TSC2, and mTOR, and those with the fibromuscular stroma, TCEB1 or ELOC in this group, and then neither of these consistently recurrent in clear cell papillary tumors. So again, this is very, sort of into the weeds. If you're not a super renal tumor enthusiast like myself, feel free to kind of ignore this slide. But these are some of the subtle differences that I think are out there between the TCEB1 mutated tumors and those with the smooth muscle stroma. So again, if you're really excited about this, feel free to take a screenshot or photograph of this reference list, but I realize that most people are not as hot on this topic as I am. So are the ELOC or TCEB1 mutated tumors, is this a diagnosis that's ready for clinical practice? My opinion is essentially no. I think these are not super recognizable at the present time. Apart from the fact that they look like clear cell tumors and they have more cytokeratin 7 labeling. So I'm not sure that you can routinely recognize this based on the morphology at the present time. The clinical significance, I think, is a bit unclear since, as I mentioned, initially it was thought that the behavior of these was quite favorable, and then the later series found TCEB1 mutations in more aggressive renal cancers. So I think we need more work on this right now, and I wouldn't fault you at all if you are not recognizing them and discriminating them from clear cell renal cell carcinomas in practice. I think I'm probably missing them because the differences between this and clear cell renal cell carcinoma is so subtle. So next, another emerging entity that I think is quite interesting is renal cell carcinoma with amplification of chromosome 6p21 that includes the TFEB gene and also frequently the VEGF alpha gene. So you probably know of TFEB as it's one of the genes involved in the microphthalmia transcription factor family of rearrangement tumors. But recently, over the past few years, it's been recognized that some tumors have amplification of this gene rather than rearrangement. And these seem to be aggressive tumors. At the bottom of the slide, there are several studies that all basically in very rapid succession found this recurring finding in a subset of renal cell carcinomas. So if you're familiar with the renal cell carcinomas having rearrangement of TFEB, also known as translocation 611 renal cell carcinomas, you might know that they have a very clear cell-like appearance, and yet sometimes they have this unusual pattern that you can see on the right with a smaller population of cells in kind of a rosette-like configuration. So this morphology was initially described in the TFEB rearrangement carcinomas, and if you see it, it is certainly suggestive, although it's not entirely specific for those rearrangements. This pattern has also been described in a subset of TFE3 rearrangement carcinomas as well. But these tumors with the amplification of the TFEB region rather than the rearrangement have a different morphology. They usually don't have that recurring small cell with rosette pattern that we saw on the last slide. They have more of an eosinophilic to clear cell pattern of cells with prominent nucleoli. Here's an example of one, a gross examination of one of these tumors. And if you tuned into my previous lecture on staging, you might know that I'm quite keen on the topic of renal cancer staging. And in this one, you might notice that the red arrows are pointing to several nodules that kind of deviate from the circular shape of the tumor itself. So those, to me, are almost inherently diagnostic of extrarenal invasion, just by virtue of the fact that they're kind of budding away from the main tumor itself. And those are almost certainly within veins that are heading into the renal sinus. As I mentioned, these tumors seem to be very aggressive, these tumors with the TFEB amplification. And here's just as an example, you can see lymphovascular invasion in one of these tumors. At the bottom there for scale is a glomerulus. And so you can see that this small kind of thrombus of tumor is filling a small lymphovascular space that's only a few times larger than a glomerulus. So this particular tumor had extensive lymphovascular invasion. The morphologies of these tumors can be somewhat variable. This one has sort of an eosinophilic papillary morphology. The nuclear features might be somewhat chromophobe-like. This one almost reminded me of an eosinophilic chromophobe tumor. And so if you encounter a tumor that looks like it's got aggressive infiltration throughout the kidney and multiple morphologic patterns, this may be a diagnosis to consider. The several studies that have recently published on these found that melanocytic markers are often positive, especially melin A. Cathepsin K is also often positive, again suggesting a sort of a similar pathway to the translocation renal cell carcinomas, which are often cathepsin K positive. And in contrast to clear cell renal cell carcinomas, carbonic anhydrase 9 is typically negative in these tumors. So if you have any of these markers available to you, if you're seeing a phenotype that doesn't fit with clear cell, it doesn't really fit with translocation renal cell carcinoma, this may be a diagnosis to consider. And here's a FISH image from one of these tumors, and this is a break-apart probe for TFEB, and although it doesn't show the typical rearrangement pattern, it shows these huge aggregates of numerous copies of the TFEB region, almost like you would see in an amplified HER2 FISH image. So is this entity ready for diagnostic practice? I would say yes. I think this is probably important. They tend to be aggressive. The study from the Mayo Clinic by Gupta and colleagues suggested that possible treatment directed at the VEGF pathway might be relevant to these tumors, since they also have amplification that includes VEGF-A. This is not an official entity yet, but most likely will be included in the chapter on the MITF family rearrangement renal cell carcinomas in the next WHO classification. So I think we probably should try to recognize this. Of course, it's an emerging entity, so it's not going to be necessarily easy to recognize in all cases. But I think we should try our best to recognize this due to the aggressive behavior and the potential for possible treatment with targeted therapies. For the next section of the talk, I'd like to move on to oncocytic tumors and talk about some of the new emerging concepts in oncocytic renal tumors. So one emerging entity in the oncocytic spectrum of tumors is something that Kirill Tripkov and myself and Andre Hess and our group proposed under the terminology of low-grade oncocytic tumor. And I'll show an example of one of these and why I think it's recognizable as a little bit different from other oncocytic tumors. So here's a case encountered in a renal mass biopsy. You can see a very bland-looking oncocytic renal tumor. Looking at high magnification, the nuclei are very uniform and regular without much atypia, and it's growing in sort of a solid eosinophilic cell growth pattern. Something that I find to be very helpful in recognizing these is that there are frequently edematous areas within the tumor where the cells kind of seem like they're stretched out and just barely loosely connecting with one another. To me, they sometimes almost look triangular in shape, reminiscent of the way that, say, cardiac myocytes are kind of loosely connected to each other at the ends of the cells. And so if you routinely use immunohistochemistry in oncocytoma, you'll know that cytokeratin 7 is consistently very minimal in oncocytoma. Some authors might say negative, but to me, the typical pattern of cytokeratin 7 in oncocytoma is labeling of basically scattered individual cells. But in these tumors, although they're very bland and oncocytic looking like an oncocytoma, they have very consistent recurring diffuse CK7 positivity, which is unusual. And if you use KIT immunohistochemistry, KIT or CD117, you might be familiar with the membranous pattern of staining that is frequently encountered in oncocytoma and chromophobe tumors, whereas in this entity, it seems that KIT is usually negative, with the exception of some mast cells being positive, as you can see in this field. So the absence of KIT staining with the diffuse CK7 staining is kind of an unusual pattern that differs a little bit from typical oncocytoma and typical chromophobe renal cell carcinoma. Here's a low magnification scan of one of these tumors, and you can see the alternation between the solid areas and the edematous areas. And I'll go to higher magnification here. You can see the sort of transition from solid growth to the edematous areas with these cells that are kind of stretched out and just barely touching one another in the edematous areas. And then on the inset panel there is the diffuse labeling for cytokeratin 7 in this example. So what's the significance of this entity? I think we don't totally understand it at the moment, but it's probably reasonable to regard it as similar to eosinophilic chromophobe or oncocytoma at the present time. At least in the past, I almost certainly diagnosed most of these as eosinophilic chromophobe renal cell carcinomas because I saw them, they looked like oncocytic tumors, and then I usually do use immunohistochemistry, and on the cytokeratin 7, I found way too much staining for a diagnosis of oncocytoma. And so in the past, I diagnosed these as eosinophilic chromophobe tumors. So I think it's very reasonable to regard them as in that spectrum for the time being, basically to counsel your clinicians that if you follow this in a manner similar to what you would do for an eosinophilic chromophobe renal cell carcinoma, that would probably be an adequate way to follow that patient. There is some emerging molecular data to suggest that these tumors also have abnormalities of the tuberous sclerosis or mTOR gene pathway, and I'll highlight some of that emerging data on the next slide. In this study from Tatiana Antic and her group at University of Chicago, they didn't use the terminology low-grade oncocytic tumor per se, but if you look carefully at the subgroups of eosinophilic renal tumors that were described in this series, what is highlighted there as group 2 of the series were noted to have solid architecture and diffuse staining for cytokeratin 7. And then in that group 2, the second highlight in the abstract there shows that variants were identified in TSC1, TSC2, and mTOR in these tumors. So this is actually an area of study for us, and we hope to have some more molecular data on these coming out in the very near future. So is this low-grade oncocytic tumor, is this ready for diagnostic practice? Personally, I think so. What I've been doing with these is that if I encounter one, I report it under that terminology without considering it a carcinoma per se, and then give a comment explaining that this is a recently recognized entity. It's probably low risk in the spectrum of oncocytoma and chromophobe renal cell carcinoma, and that if you regarded it as similar to those for follow-up purposes, that would likely be reasonable. Another emerging entity that sort of continues on the same theme here in terms of oncocytic tumors and actually in terms of the similar genetics is an entity that's been described under two different terminologies: high-grade oncocytic tumor, or HOT, and renal cell carcinoma with eosinophilic and vacuolated cytoplasm. And so, as I mentioned earlier, the Genitourinary Pathology Society recently published kind of a consensus paper on kidney tumors. And in that paper, it was proposed to sort of bring together both of these names under a new name of eosinophilic vacuolated tumor that kind of sort of hybridizes both of the two names that have been proposed for this entity. So here's an example of the histology of one of these tumors. You can see cells that are sort of pale to eosinophilic. Again, in the past, I almost certainly would have diagnosed these as chromophobe renal cell carcinomas. You can see it has prominent cell borders, very similar to chromophobe renal cell carcinoma. And when you look at high magnification, many of the cells have prominent nucleoli, and the cytoplasm kind of varies from eosinophilic to containing these sort of flocculent vacuoles in the cytoplasm. Here are some also entrapped renal tubules within the tumor here. So the immunohistochemistry of these tumors is generally nonspecific. They can be positive for KIT or CD117, much like an oncocytoma or chromophobe renal cell carcinoma. Cytokeratin 7 is usually negative or focal, and cathepsin K is often positive, which may be a clue that we've used in a subset of these cases to help recognize this entity. Molecularly, as I mentioned, the study from Yingbe Chen and colleagues in the American Journal of Surgical Pathology showed that these seem to have mutations of tuberous sclerosis and mTOR genes as well, particularly TSC2 and mTOR. And here are the two studies that were published under using the different names: high-grade oncocytic tumor and somatic mutations of TSC1 to an mTOR in a subset of renal cell carcinoma with eosinophilic vacuolated cytoplasm. So as I mentioned, the GUPS consensus that was recently published proposes a new name of eosinophilic vacuolated tumor to kind of hybridize these two names. Tumor implying that they are probably non-aggressive, and vacuolated highlighting their consistent morphology. So is this one ready for practice? I think it probably is. We've been able to recognize some of them now prospectively in practice since the publication of these papers. Like low-grade oncocytic tumor, I've been giving a very similar comment that basically I would probably follow this patient in a manner similar to what you would do for chromophobe renal cell carcinoma. Almost certainly most of these would have been diagnosed as either as most likely chromophobe renal cell carcinoma in the past. Particularly this one I think would be less likely to be diagnosed as oncocytoma in the past. And again, it's probably reasonable to follow them like a chromophobe renal cell carcinoma for clinical purposes. So another entity that's perhaps not as new and emerging as those that we just talked about, but also relevant to the oncocytic tumor spectrum, is succinate dehydrogenase deficient renal cell carcinoma. SDH deficient renal cell carcinoma is, of course, now included in the WHO classification since 2016. So this is less of an emerging entity and more of a recently established entity. But the helpful diagnostic features to recognize these tumors are that they have, again, very monotonous eosinophilic cells. They have cytoplasmic vacuoles, as you can see here. However, if we go back to the eosinophilic vacuolated tumor that I just mentioned, if we use SDH immunohistochemistry, those tumors show a normal pattern for SDH immunohistochemistry, whereas these show an abnormal pattern that I'll demonstrate in a minute. But again, the characteristic feature of SDH deficient renal cell carcinoma is cytoplasmic vacuoles, like you can see here. Or in some cases, the cytoplasmic inclusions will be more of a globular appearance. At least some data from electron microscopy suggests that these are giant abnormal mitochondria. Although they're usually very solid, occasionally they will have a tubular or cystic component like you can see here. And they frequently entrap benign tubules, like as you can see in this image. Something that we found in the study that we conducted on these tumors a few years ago is that mast cells are very common. So they're kind of blown up. You can see a prominent mast cell within the tumor. And luckily, we have a relatively helpful biomarker for diagnosis of this tumor that is SDHB immunohistochemistry. And so if you use SDHB immunohistochemistry, you can show that the tumor cells have abnormal absence of staining. In this field, you can see there are some normal tubules entrapped. However, the tumor cells have nearly a complete absence of SDHB immunohistochemistry, suggesting that something is wrong with the SDH protein. And luckily, regardless of which of the SDH subunit genes is mutated, it appears that the SDHB immunohistochemistry will become negative regardless. So it sort of destabilizes the enzyme complex and is negative regardless of which gene is mutated, making it helpful as kind of a screening tool. These are positive for at least some renal epithelial markers, especially PAX8. However, they can have inconsistent labeling for cytokeratin and EMA, other epithelial markers, as you can see here. This one is negative for cytokeratin, but positive for EMA, although both of them can be variable. As I alluded to earlier, oncocytoma usually has scattered cells positive for cytokeratin 7, a very minimal number of scattered cells positive. But SDH deficient tumors usually have 0 cells positive for cytokeratin 7. Here on the c-Kit and vimentin stains, you can see that they're negative in the tumor cells. However, there are numerous mast cells that are highlighted by both of these markers in this particular case. So SDH deficient renal cell carcinoma, of course, I would say it's ready for routine practice because it's already, in fact, included in the WHO classification. And I think this is just important, and I wanted to touch upon it today, even though Dr. Clouston, I believe, also did touch upon it in his lecture, because this is deceptively bland, yet malignant. And the diagnosis of this entity strongly implies a hereditary syndrome, the SDH syndrome that's associated with multiple pheochromocytomas and perigangliomas, as well as gastrointestinal stromal tumors. So while we're on the topic of oncocytic tumors, I'd like to share a case. This was kindly shared with me by Dr. Stephen Smith from VCU. And this is, as you can see here, this is a sort of bland oncocytic tumor. And if we go to higher magnification, you can see sort of a solid growth of eosinophilic cells with kind of haphazard architecture, but not very high grade or pleomorphic cytologic features. And recently, Dr. Smith and his colleagues showed that occasional patients with fumarate hydratase deficient renal cancers will have this low-grade oncocytic morphology. So I didn't really touch upon in this lecture today HLRCC-associated tumors or fumarate hydratase deficient renal cancer, which is the hereditary leiomyomatosis and renal cell carcinoma syndrome. But as probably many of you know, those are very aggressive tumors that are associated with a so-called type 2 papillary morphology. They have heterogeneous morphologic patterns and very prominent nucleoli. However, Stephen Smith and his colleagues showed that occasionally you can encounter a very uniform oncocytic morphology in the FH deficient renal cancers, very similar to what we see in the SDH deficient renal cancers. And so like SDH deficient renal cancer, if you use immunohistochemistry for the fumarate hydratase protein, you can show that these are abnormally negative for FH, sort of confirming this diagnosis. So that's sort of yet one other thing to consider in your differential diagnosis of these low-grade oncocytic renal tumors. So is this unusual variant ready for routine practice? I would say, again, probably yes, especially because it heralds the very serious HLRCC syndrome, at least in most patients that we know of. So in the series by Stephen Smith and colleagues, the tumors that were purely low grade did not appear to be as aggressive. So those patients didn't necessarily, if they had only low grade tumors, they didn't necessarily die or have metastatic disease, but there were only 2 in that series. So I don't think we can totally extrapolate that at present. And yet some of the patients also had high grade tumors in addition to the low grade tumors. And those high-grade tumors did behave aggressively. So again, probably the diagnosis of one of these tumors implies that the patient has the HLRCC syndrome, at least in the vast majority of cases. And again, this is important to avoid misdiagnosis as a benign or low-risk tumor, like some of the other ones that we've mentioned in the past. Another emerging entity that I think is now recognizable as a distinct subtype of renal cancer is so-called eosinophilic solid and cystic renal cell carcinoma. This unique morphology was initially noted in studies of tuberous sclerosis patients. However, subsequent to that, it was found that this similar histology can occur in non-tuberous sclerosis patients. And in particular, it seems to have a strong female predilection. So here's the histology of one of these tumors. You have solid eosinophilic cells, and then cystic areas with sort of hobnail-shaped eosinophilic cells that are similar to those in the solid areas lining the cystic spaces. And so the name for this was proposed as eosinophilic solid and cystic renal cell carcinoma. Initially, a couple of studies that I mentioned earlier looked at the renal cancers in tuberous sclerosis patients, and this was yet another interesting morphology that was found in those studies. The one study here sort of divided renal carcinomas into 3 major patterns, one of which was called the granular eosinophilic microcystic pattern, which would later come to be known as eosinophilic solid and cystic renal cell carcinoma, or ESC-RCC. The other study from this group described 2 major patterns in tuberous sclerosis patients and also an unclassifiable group, but both of them had very similar findings in tuberous sclerosis patients. So then subsequently, Kirill Tripkov and colleagues proposed the name eosinophilic solid and cystic renal cell carcinoma for these tumors. This was a cohort of apparently sporadic tumors that occurred almost exclusively in women. And one of the interesting findings that was noted is that they are frequently positive for cytokeratin 20. And if you're like me, you probably have very rarely used cytokeratin 20 immunohistochemistry at all until the recognition of this entity. But now that we're aware of it, I think that's a helpful tool to at least sometimes recognize this entity. So Kirill Tripkov and colleagues again also described a second cohort with further morphologic characterization and looking at molecular karyotype abnormalities in the second paper. But then shortly after that, 3 groups in very rapid succession found that these were characterized by somatic mutations of the tuberous sclerosis genes. So the tuberous sclerosis genes are really making up sort of a recurring theme in our lecture today. I think there's a lot of interest in the tuberous sclerosis genes in these emerging subtypes of renal cancer. So here, this study from the University of Chicago group showed that eosinophilic solid and cystic renal cell carcinomas, even those that appeared to be sporadic, had mutations of the tuberous sclerosis genes. Another one from the Johns Hopkins group showed that the same findings, that there are recurrent TSC mutations in renal cell carcinomas. And then another one from Rohit Mehra and his group at the University of Michigan found the same, that there is somatic biallelic loss of TSC genes in these tumors. So basically, again, in rapid succession, 3 groups found similar recurring genetic findings in these tumors, which to me sort of sealed the deal that this is a recognizable entity in renal cell carcinoma classification. So here's a high magnification showing some of the features that I think are helpful for recognizing this entity. They have this unusual finding of cytoplasmic stippling, or this sort of basophilic material in the cytoplasm. To me, that resembles Nissl substance, although if you look at some of the original manuscripts, one proposal was that it was reminiscent of leishmaniasis. So whatever you are more comfortable with seeing in practice, it's sort of this unusual basophilic stippling in the cytoplasm of cells is one clue to the recognition of this entity. Typically, there is some positivity for cytokeratin 20, although that is not a requirement. It is possible to have one of these tumors with entirely negative cytokeratin 20, but if you would like to use a marker to help you in classification of these, that's very frequently positive, cytokeratin 20. Almost all of the patients are female, although there have been some exceptions. And at first it was thought that these had very favorable behavior, but a few metastatic cases have been recently reported. So it seems that classification of this tumor as a carcinoma is likely warranted. And here's just one higher magnification inset showing the sort of basophilic stippling of the cytoplasm in this tumor. So is the eosinophilic solid and cystic renal cell carcinoma ready for practice? Again, I would say yes. Several groups with very similar findings have all endorsed the recognition of this entity as a distinct entity. And I think it will most likely, from what I'm aware of, be included as a distinct entity in the next WHO classification, which is in progress now. For treatment purposes, it would likely be treated as a non-clear cell renal cell carcinoma. And as I mentioned, it was initially thought that these are non-aggressive, but a few metastases have been described, so likely we should consider them malignant. Although this was initially described in tuberous sclerosis patients, it appears that probably a minority of the patients have tuberous sclerosis. So it is possible, and if your patient has any stigmata of tuberous sclerosis, you could explain that to clinicians, but it seems that many of these are sporadic. Again, much like I mentioned with VHL disease and clear cell renal cell carcinoma, if you have a germline mutation, you're more prone to develop certain histologies, but you can still develop these histologies through multiple genetic hits to the same genes. Another entity that's been sort of hanging around in the provisional category for a number of years is so-called thyroid follicular-like renal cell carcinoma. This has been sort of stuck as a provisional entity for a number of years because not a whole lot of cases have been reported, and it seems that there's some overlap with other renal tumor types. But these tumors, in brief, resemble thyroid follicles with a colloid-like secretion in the lumen. So again, as I mentioned, so far has been sort of stuck as a provisional entity, and to my knowledge is not planned to be included as a definite entity in the WHO classification as yet. But here's an example of one that I think is the best example I've encountered. You can see these small follicles with eosinophilic colloid-like material that resembles thyroid follicles. Here's another field that kind of would make me wonder about things like a solid papillary renal cell carcinoma, a metanephric adenoma, or a neuroendocrine tumor. And I'll show here how I used some immunohistochemistry in this particular case that made me think this was unlikely to be a papillary renal cell carcinoma. You can see the Amicar labeling is very minimal, whereas in papillary renal cell carcinoma, Amicar labeling is usually extremely strong and diffuse and uniform. WT1 is negative in this particular case, arguing against a metanephric tumor, and then neuroendocrine markers were also negative, arguing against a carcinoid or well-differentiated neuroendocrine tumor of the kidney. So to me, the example that I just showed, I think, was the best case that I've seen of what I think is convincingly a different entity. If you use immunohistochemistry, thyroid markers should be negative. Some of the studies have had variable results with PAX2 and PAX8, although it seems likely that most of these are positive for PAX8 supporting their primary renal lineage. Other markers like cytokeratin 7 and vimentin have shown variable results, but sometimes negative. So there's not a whole lot of great genetic data on this entity. One study found that there was a different gene expression pattern compared to clear cell and chromophobe renal cell carcinomas, but other than that, we don't have great genetic data on thyroid follicular-like renal cell carcinomas. Again, a few metastases have been described, suggesting that it is warranted to consider this a carcinoma. Is this ready for practice? I guess I would say maybe. Of course, it doesn't seem that it's on track to be a definitive entity in the current classification schemes. However, if you have a tumor that you think fits this box and it doesn't really, and in particular, doesn't really fit for a diagnosis of papillary renal cell carcinoma, this can be given as sort of a descriptive diagnosis for a renal cell carcinoma not fitting existing entities. For treatment purposes, it would likely be regarded as a non-clear cell type, particularly if the patient has metastases. In treatment algorithms, most renal cell carcinomas are treated as either clear cell or non-clear cell, and this would be likely lumped into the non-clear cell category. It is important to distinguish these from metastatic thyroid cancer, which on the surface might seem silly, but rarely can occur that you have thyroid cancer metastatic to the kidney. And so this is an example actually of a patient with known thyroid cancer who had a metastatic thyroid follicular carcinoma involving the kidney on a renal mass biopsy. Here you can see the TTF1 staining of the thyroid follicular carcinoma metastatic to the kidney in a renal mass biopsy. Recently, a major study was published on the entity that's been described as atrophic kidney-like lesion. And for several years, I think many people were uncertain, myself included, as to whether this was the same as thyroid follicular-like renal cell carcinoma or different. But I think now the authors of this recent study, Leil Hurlitz, actually, who works here with me at the Cleveland Clinic, and colleagues, published an interesting study proposing that this actually may be more of a mass-forming tubular atrophy and glomerulocystic change rather than an actual neoplasm. So I'll show a couple of examples here that were kindly shared with me by my colleague Jesse McKinney. Here you can see these sort of follicular-like spaces that are filled with various cells, inflammatory cells, and calcification. Some of them have a hint of structures that are reminiscent of glomeruli within the cystic spaces. Here's another high magnification image showing some calcifications and small cells floating in the lumen of these spaces. So is this atrophic kidney-like lesion ready for practice? I guess I would say maybe. I think we need more data on this entity. There's really only the one major study at the present that has a significant number of cases. I think if you encounter a tumor that you think in practice fits well with this category, you could convey that it's currently debated whether this should be considered a neoplasm or a form of localized cystic change and therefore presumably benign. But I think it would be interesting to gather more data on this rare form of renal tumor. But at least preliminarily, the hypothesis is that this is a localized atrophy or cystic change rather than a true neoplasm. How about the topic of oncocytic papillary renal cell carcinoma? This is, again, a concept that has been around for quite a while, but has not really gained traction as a distinct entity for a number of years. Probably one of the reasons for that is the criteria have varied across studies. However, very recently, in the last couple of years, some data have emerged suggesting that perhaps there is a distinct subtype of oncocytic papillary tumor within this category of tumors. And so some of the work has been pioneered by Khalil Al-Obeidi and colleagues from Indiana University. A few years ago, published a nice series describing the morphology, immunohistochemistry of these tumors. And then very recently showed that recurrent KRAS mutations are common in these tumors, sort of establishing a recurrent genetic abnormality. And of course, although those papers have gained attention recently, this is not an entirely new concept. Dr. Kunju and colleagues from University of Michigan published on this very same entity back in 2008 under the terminology of papillary renal cell carcinoma with oncocytic cells and non-overlapping low-grade nuclei. But very recently, at the bottom of the slide here, just to show you several slides and several groups in rapid succession have found similar findings in these tumors with recurrent KRAS gene mutations, suggesting that this does likely deserve consideration as a distinct entity. So here's the histology of one of these tumors. You can see that it has very uniform eosinophilic cells with the nuclei that are sort of aligned up away from the basement membrane. One of the findings that was found very consistently in this entity is that GATA3 immunohistochemistry is frequently positive, discriminating it from typical papillary renal cell carcinomas of other morphology. Another group has used the terminology of oncocytic papillary renal neoplasm with inverted nuclei, but it seems that the most common name that's now emerging for this entity is papillary renal neoplasm with reverse polarity, which is listed at the top of the slide there. So far, it seems that this is a non-aggressive tumor, and some of the helpful immunohistochemical features that could help you to recognize it would be that GATA3 is consistently positive. Vimentin is usually negative, which sort of resembles oncocytoma and is different from other papillary renal cell carcinomas. However, c-KIT or CD117 is negative, contrasting to oncocytoma and chromophobe renal cell carcinoma. Of note, Amicar staining is variable. Although it can be positive, it's usually not as strong, uniform, and diffuse as what is typically seen in papillary renal cell carcinoma. So that sort of differs. And cytokeratin 7 is often positive, which contrasts to just oncocytic renal tumors in general, which usually have basically, usually the more eosinophilic you are as a renal tumor, the less cytokeratin 7 labeling you have. However, although this is, I think, now gaining traction as likely a distinct entity, not everything that looks papillary and eosinophilic fits into this category. So a recent study by Andre Hess and his group from the Czech Republic showed that if you cast a wider net and look at renal cell carcinomas with eosinophilic cells, there are eosinophilic renal cell carcinomas that don't fit into that entity that we just talked about, the papillary neoplasm with reverse polarity. Here's a papillary renal cell carcinoma with eosinophilic cells. You can see the nucleoli are prominent, and it doesn't really show obvious alignment of the nuclei like we talked about. Other areas of this one have foamy histiocytes like a typical papillary renal cell carcinoma, and other areas you can see kind of compact, crowded papillary structures. This one is positive, at least somewhat, for Vimentin, strongly positive for Amicar, and only patchy positive for cytokeratin 7. So to me, this would fit more in keeping with just a regular papillary renal cell carcinoma with eosinophilic cells. But if you do have a tumor that meets all the criteria for the papillary neoplasm with reverse polarity, including the low-grade alignment of the nuclei, is that ready for practice? I think it probably is. You could make this diagnosis and then convey in your report that in the past these may have been classified as papillary renal cell carcinomas. Emerging evidence suggests that they are different. Excuse me. And so far, it seems that they have favorable behavior, although we need more data. To touch upon, while we're on the topic of papillary renal cell carcinomas, I just wanted to touch upon a new variant that's been recently recognized. Initially, this variant was described under the terminology of biphasic squamoid alveolar renal cell carcinoma, although now I think we know pretty convincingly that this is probably just a variant of papillary renal cell carcinoma. It seems to have the same immunohistochemistry and genetics as papillary renal cell carcinoma, but it has this unusual pattern of clusters of more eosinophilic cells that are almost squamoid looking in the lumen of the glandular structures, as you can see on the right. For some reason, there seems to be increased staining for cyclin D1 in those eosinophilic cell areas. And so this is an entity, I think, in pathology where when you see a case with an extreme version of this morphology, you might be confused and not sure what to do with it. But once you're aware of it, if you look carefully at your routine papillary renal cell carcinoma cases, you'll actually start to notice this finding to a subtle and focal extent fairly regularly. So when you see an extreme one, it may look like unusual squamous features within a papillary renal cell carcinoma. But if you look carefully, this is not too rare within papillary renal cell carcinomas. So is this ready for practice? Basically, you can just diagnose it as a papillary renal cell carcinoma. I don't think there is an urgent need to specifically describe that terminology. That might be confusing if you issue that as your primary diagnosis in a report, but it can be lumped together with papillary renal cell carcinomas. Actually, a recent study found that there seemed to be a higher frequency of MET alterations in tumors with this morphology, which was just published in Modern Pathology. Apologize, it's a little bit cut off there, but hopefully you can see the reference. So MET alterations are one of the hallmarks of papillary renal cell carcinoma, although until recently we thought those occurred only in a relatively small subset of papillary renal cell carcinomas. But it appears when you look enrich for this histology, they are more common. And finally, I believe this is the last thing that I wanted to touch upon, is renal cell carcinoma with ALK gene rearrangement. This is, again, an emerging area, although several different morphologies have been described in renal cell carcinomas with ALK rearrangement. So it's not entirely clear that there's one recognizable morphology that you can see and say, this is most likely a renal cell carcinoma with ALK rearrangement. However, some of the features that have been found to be sort of suggestive of renal cell carcinoma with ALK rearrangement include a mucinous or myxoid background, a medullary-like morphology, in particular patients of young age, and a subset of these patients seem to have sickle trait. So if you have a patient with a sickle trait, and we all likely know that they often develop renal medullary carcinomas, but if you have a tumor that really doesn't fit the morphology of renal medullary carcinoma with loss of INI1, SMARCB1, another possibility might be renal cell carcinoma with ALK rearrangement. So these images are courtesy of Andre Hess from the Czech Republic. You can see this tumor has kind of a eosinophilic, almost papillary-like morphology, but there is some basophilic mucinous material within the tumor. And again, so the way I approach this is that if I have a renal cell carcinoma with unusual features, some myxoid features, perhaps occurring in a patient of a young age, or I'm just getting desperate and I really can't classify a very unusual renal cell carcinoma, often I will use ALK immunohistochemistry as a screening marker for whether the tumor may have ALK rearrangement. At least coming from data from the lung, it appears that ALK immunohistochemistry is a fairly sensitive marker to detect the gene rearrangement. So I usually use immunohistochemistry as a surrogate, and only if there is some degree of positivity to pursue it further with molecular studies or FISH. So is ALK rearrangement renal cell carcinoma ready for practice? It's not very morphologically recognizable as yet as just one unique recurring morphologic pattern. However, for treatment purposes, it might be relevant. Some studies have suggested that a treatment with ALK inhibitors may be useful for these patients. So I think it is worth trying. If you have an unusual renal cell carcinoma, particularly in the metastatic setting, the tumor is not fitting cleanly into a specific diagnostic entity, the possibility of considering ALK rearrangement renal cell carcinoma might be worthwhile. So for the most part, treatment of renal cancer just depends on clear cell and non-clear cell subtypes. So I wouldn't get too worried about recognizing all the subtleties of these emerging entities, but hopefully I was able to convey today some of the things that I think are ready for diagnostic practice and some of the subtleties that do have some clinical relevance. Some of these tumors have specific implications in terms of their aggressiveness, like the HLRCC-associated tumors. Some of them have implications for hereditary syndrome, like HLRCC and SDH-deficient renal cancers. And some of them are, of course, non-aggressive, like most of the oncocytic tumors that we talked about today. And so thank you again for tuning in. I apologize, I went pretty close to using most of our time, but hopefully there is still a little bit of time for some questions.
Thank you very much, Sean. That was excellent as ever. We've got a few questions. The first one really is, as we started off, someone asks, what sort of nuclear grade would you allow for the RCC with leiomyomatous stroma? Because we always say, obviously, the clear cell papillary always are low grade nuclei. Is there a specific grade that you'd say, oh, this is a high grade? So is there a grade specific for that entity?
Yeah, that's a great question. When the first study that I did a few years ago, when I was looking at these, I noticed that they can be a little bit higher grade than clear cell papillary renal cell carcinoma. So clear cell papillary almost entirely seem to be grade 1 or grade 2, but occasionally we have seen more like a grade 3 nuclei in these tumors with the smooth muscle stroma. So to me, if it's a slightly higher grade, actually, I think one of the tumors that we included in our original series of clear cell papillary renal cell carcinomas back from, I think, 2013 or so, in retrospect may actually have been one of these with the smooth muscle stroma. So I think that the grade can be a little bit higher. Sort of just barely reaching a grade 3 is more common in the smooth muscle tumors than clear cell papillary.
And the next question was, could a low grade oncocytic tumor, is it reactive with S100A1?
That's a good question. I haven't used that marker in particular myself too much. I'm trying to remember if it was used in the series that was written by Kirill Tripkov and colleagues. I haven't used that marker too much myself, and so I don't remember offhand. But if you have a chance, you could take a look at the study by Tripkov in histopathology. I'm not 100% sure off my memory if it was used in that study, but there was a pretty comprehensive list of markers used in that study.
This is a really thinking outside the box. They ask, in cases of RCC with leiomyomatous stroma, could we consider the lymph node involvement as multifocal tumor rather than metastatic, like we would be encountered in an angiomyolipoma?
Yeah, that's a great question. I've sort of thought about that myself, and yeah, and because you're right, in angiomyolipomas, especially in tuberous sclerosis patients, I have seen angiomyolipomas in lymph nodes. Patient has one in the kidney and also one in the regional lymph nodes. And could that be sort of a multifocal involvement? I don't think myself I have seen one of the metastatic lesions, but I believe from the publications there was also the epithelial component in the lymph nodes. And so, I guess to me, at least at the moment, I'm stuck with regarding those as carcinoma, since there's an epithelial component in the lymph node. But yeah, that I wondered that same thing, and I don't know if there's a great way to test test that hypothesis, except for perhaps that if the patients continue to do well, even with those lymph node involvement, they don't have further metastases. But yeah, I wondered that.
So another question, does SDHB have to be completely negative to support SDH deficient RCC? We've seen cases with markedly reduced staining but not absent. This is a question which I often come, because I find the SDHB staining a bit iffy sometimes. Is that your experience?
Yeah, I think it depends a lot on your laboratory and the staining conditions and things. And in general, I think markedly reduced staining is at least very suspicious, if not diagnostic as well. I guess the way I think of it is that eosinophilic renal tumors tend to be eosinophilic because they have lots of mitochondria, and so SDH being part of the mitochondrial, part of the Krebs cycle. Most of the time, eosinophilic tumors with lots of mitochondria will have extremely strong staining for SDHB. And so if you have markedly reduced staining, at least in most cases, I would say that's at least highly suspicious, if not diagnostic for deficiency. It probably depends on your staining conditions. But I think we encountered one like that in our practice rather recently, where it wasn't entirely absent, but there was kind of a diffuse low level of staining that was much less than even, say, adjacent smooth muscle, which made me fairly convinced that it was a true deficient pattern.
So here's a staging question, combining two of these questions together. So how do you stage tumors with leiomyomatous stroma in which the stroma is extending into the fat?
That's a great question. Yeah, so we published a series in 2015 in Modern Pathology, and so just by convention, we just sort of chose the arbitrary convention that we would only consider it a higher stage if the epithelial component extended into the adipose tissue. And so that's sort of the way I've been handling it, is if the smooth muscle kind of goes out and wraps into the adipose tissue, but not the epithelium, then I wouldn't consider it higher stage. But I guess we don't really have any great evidence that that's the correct way to do it, since there's not much aggressiveness in either case. But that's been sort of my working convention in the absence of better evidence.
This is quite a long one, so you have to bear with me. So recently received a very oncocytoma-like tumor, morphologically, but diffuse strong CK7 in all cells. C-kit a bit equivocal in the original sections. C-kit is very minimal and focal in rare small groups of tumor cells, not just the mast cells. Also, almost all tumor cells are negative. I think you described focal weak C-kit in 2 out of the 28 cases in your series of LOT. We did suggest low-grade oncocyte tumor as the most likely diagnosis. No chromophobe nuclear morphology present. Only fly in the ointment was the lack of edematous stroma with the stretched cells you illustrated. I think this just suggests that there'll be many, many more years of classification redos of all the these renal tumors. I mean, how solid is the category of LOT? Do you find cases which will sort of sit on the borders of this entity?
Yeah, I mean, I agree. I also recently had a case which, I looked at the morphology and immediately thought, oh, this looks like a low-grade oncocytic tumor or LOT. And then the CK7 was diffuse, but just as you described, the kit was actually there was some cytoplasmic staining and focal membranous staining. This was a consultation case, so I repeated the kit staining in our lab, and it was more like a negative result with just the mast cells in our lab. So that may depend a little bit on different staining conditions or other parameters. the kit staining. But I guess the one, since we published the series, the ones that I've seen, I think when you see that edematous stroma and the very solid morphology, it's kind of like almost an instant recognition where you say, oh, this is going to be one of these. But I'm sure that you're right that as we gain experience with them, probably maybe the morphology, the spectrum will be more broad than we think, and we might have to include more things. Actually, I'm working on a project with some collaborators right now that we're starting to think that maybe there may be more of a broad spectrum of morphology than just that tight group that we initially found.
And we're coming to the end of our allotted time, but there's one more. How frequently have you seen renal vein invasion by clear cell papillary renal cell carcinoma?
I think I've only seen that once. A colleague of mine shared a case with me that was a consultation case, and really everything looked like a clear cell papillary renal cell carcinoma, except it had renal sinus / renal vein invasion. So I think I've seen that only once. I believe in some of the series there might have been an occasional perinephric invasion. I think I've seen, but myself, I think I've only seen it once. The involvement of veins by clear cell papillary renal cell carcinoma. So, I mean, if we extrapolate that, oncocytomas have been described to go into renal veins, and that hasn't necessarily changed their behavior.
Yeah, I have to be slightly careful though, because of course you can get some clear cell papillary-like areas within a bog standard clear cell. So you need the immunoprofile, really, don't you, to confirm?
Yeah, very true. Yeah, I mean, I've been keen on that. That everything, to me, everything has to be really perfect to make a diagnosis of clear cell papillary renal cell carcinoma. If it's a larger tumor with necrosis or high grade, and then if the immunohistochemistry is not entirely perfect, I usually shy away and instead interpret that as a clear cell renal cell carcinoma. And there are a couple of studies, one that we did and one from some of my colleagues here at the Cleveland Clinic before I came here. They published one that was very similar, showing that if things are not perfect, it's probably better to regard that as a clear cell renal cell carcinoma. So yeah, that's a great point. Thanks for mentioning that. Yeah.
Thank you, Sean. I think we've probably run out of time. There are a few more questions, but if anyone has any burning questions, they can just email you. So thank you again for giving an excellent lecture, and thank you for everyone who's listened. Thank you.
Well,